outset, I would like to thank all the office bearers of APAO for honoring me with this lecture, which is named in memory of Dr. William J. Holmes, who was one of the founding members of APAO in the year when it was started in 1960, and he was also the founding Secretary General of APAO at that point of time. And for this lecture, I have chosen the topic, the journey of improving cataract surgical quality through monitoring and benchmarking in our organization. And the RAVINDRAN hospitals, I just want to give a brief background because we have several international delegates. So it was started by Dr. G. Venkatsamy in the year 1976. It has grown into a network of 14 hospitals, 8 community eye clinics, and 117 primary eye care centers. And the year 2023-24, the financial year, we had seen about 6 million outpatients, and we have performed about 700,000 plus surgical procedures, which also includes about 448,000 cataract surgical procedures. And over the last 50 years, we have done about 10 million procedures, and 50% of that is free or subsidized care. And all this has been possible because of the trust the patients have on the organization. And I can attribute to two things. One is the patient-centered approach and our attention to the quality in the patient care part. And if you want to understand the quality, what it means, it is also good for the staff of the organization, any hospital to understand, is that it has got 6 elements as put forth by the Institute of Medicine in America. The 6 elements are the safety, patient-centered care, effectiveness, efficiency, the timeliness of the care we provide, and also the equity. And for today's talk, I'm going to talk about the safety and the effectiveness part of it. And the patient safety is the base for quality, and we are all aware, that patient safety is about treating the correct patient, correct site, the correct treatment, and not harming the patient. Especially in our context, it is about preventing sight-threatening complications. And in the part about improving patient safety, I'm going to touch upon how do we minimize safety errors in our practice, how do we minimize globe perforation in anesthesia. The third part is about how do we minimize post-operative endophthalmitis. So the safety errors is something which we don't talk about much in our meetings. The incidence of safety error in the hospitals around New York, there was a publication in the year 2007 titled Surgical Confusions in Ophthalmology. There they talk about wrong IOL implants, wrong eye surgery, wrong eye block, wrong procedures happening in about 62 cases out of 900,000 procedures which were done over a period of 6 years. And they are all reported to a local organization, which works out to about 1 per 15,000 procedures. And they also go on to say that nearly 85% of this could have been prevented if the safety protocols have been followed. There is a recent paper in 2018, JAMA Network, which looks at the incorrect procedures which happen in the Veteran Hospital Administration, which is a large chain of network of hospitals across America. They looked at 8-year data of about 3.23 million surgical procedures, not just ophthalmology, but all specialties. And they found there were about 277 incorrect procedures, and they also prevented 206 close calls. This 277 included about 90 wrong side procedures, about 86 wrong implants, many of which were ophthalmology related, and wrong site, for example, operating on a wrong vertebra or on a tooth. So these are all not high volume, these are all low volume centers. Even there you have incidents, the sentinel events happening. And it has affected all these surgical specialties, as you can see. But you can see on the top is ophthalmology with 72, nearly 25% of these incidents happened there. While other surgical specialties, it was 1 per 20,000. In ophthalmology, it is about 1 in 10,000. And here again, performing a comprehensive timeout probably could have avoided many of these errors. And all of us, all our practices, whatever be our size, we always have come across something going wrong. Because the safety errors in eye care is very prevalent because we have bilateral organs, it's a high volume specialty, and we have to take multiple measurements where no documentation errors can happen. There are also multiple team members can be involved, and we have a fair share, large number of patients who are vulnerable patients, who are hard of hearing, they have dementia, mentally challenged, and very old patients. So to that, I am in this context, when you already have so much of complexity, in Aravind in a day, we handle about, especially I've taken an example of Aravind Eye Hospital, Madurai for this talk. We handle about 3,500 plus patients on a daily basis. We do about 700 surgical procedures, and that is done by about 200 surgeons assisted by 1,000 plus allied health personnel. And the most important thing is that each patient is touched at least by 10 to 12 ophthalmic personnel in the organization. So it is not uncommon that in the year 2012, of the 146,000 surgeries and other procedures we had about 23 errors, which accounts to about 1 per 6,500 patients, even though none of these patients lost vision and some of them may had a resurgery. But still, it is important that we have to prevent such errors in our practice. So we had taken to understand what really causes. We really understood when we look into these issues, we found that it is not the people who deliver the final care or not the people, which we call it as acute failure. Everything has been done very well. The people who have done previously have done a good job, but the surgeon who is doing it or somebody who is giving an anesthetic block fails. So it is always because of the lack of safety culture. When I say that, it is absence of formal protocols and processes to ensure safety. It is also non-adherence to the protocol, and sometimes all are there, documentation errors happens and lack of communication. So it's only the policy, process and the technology, not the people. When these are involved, policy and process, technology, then it is about, we call it system failure, and nearly it accounts for 90% of the errors in most of the places. So we adopted several processes, which I'll go through one by one. But the first part is we had an awareness meeting amongst all our hospitals to understand what goes wrong in our hospital. We discussed all the errors. That was sometime in 2011 and 12. And we also introduced an online reporting form, which is available and is anonymous reporting. Once we introduced that, people reported what goes wrong, not necessarily safety, but related to patient centeredness, efficiency, effectiveness, all of that. And we are also able to clarify the safety goals for the organization. We clarified about 10 different goals. Actually, this talk, I'm only talking about the goal 1 and the goal 2 part, and also the goal 4, which is about preventing hospital-acquired infections, and goal 5, which is sight-threatening complications. And we had developed standard protocols for 16 different areas, developing Word documents, policy documents, PowerPoint presentations for training, posters and videos, so that everybody is aware of that and everybody is involved. But the underlying theme is, it's all about correct patient identification, either in outpatient clinic or in an inpatient clinic. And it's all about eye marking to make sure that the correct eye is operated. And one of the issues we used to have is wrong eye block, anesthetic block. So we made sure that there was an allied ophthalmic personnel or ophthalmic technician or nurse will stand with the doctor when the anesthetic block is given. When we did that, it completely went away. Very often this is something is done by the doctor alone. And instead of having a timeout only in the operating room, we had timeout at least in 2 other locations to make sure that all the documents, everything is in the case sheet or there, and all investigations, including biometry, have been done. The intraocular lens is available. So we make sure that the organization, the surgical procedures also go on very efficiently. So I'm just sharing for the last year, I showed you that in 2012, we had 23 errors, 1 in 6,500. In the year COVID, our volumes dropped significantly. We probably saw about 40% of the surgeries. And there it went down, which was 1 in 6,500 has become 1 in 37,000. We just had 2 errors. But the next year, the volume picked up, almost became double, and the number of errors also increased, and it became 1 in 23,000. And the year 2022, we had 189,000 procedures with 5 errors, which is 1 in 37,000. In 2023, it was 1 in 47,000. And last year, for the very first time, we did not have any error, in spite of the volume we had. And and it's all been possible only because of the involvement of the staff and the culture we were able to build, and we hope to continue to maintain this in the coming years. So what we have done to prevent the safety errors is we have identified areas where errors happen in our practice. We understood how they happen. The root cause, understanding why it happens, how it happens, only then you can come up with a proper solution. So we also created independent checks for key processes. A doctor advises, for example, a patient, a right eye, left eye surgery. The next person who sees the patient, who is a counselor, has to ask an open-ended question to understand the doctor has done the job correctly. She will also check whether the surgical advice is also correct. So creating this culture by involving multiple people and creating safety teams becomes very, very important. The second part of this patient safety is about minimizing globe perforation. The globe perforation ophthalmic anesthesia varies anywhere from 6 to 130 per 100,000. These are all from the literature. In RAVINDRAN Hospital in Madurai, from 2013 to 2015, in the 3 years, we had done about 289,000 surgeries, and we had about 13 globe perforation, which is about 4 per 100,000. And subsequent year, we completely transitioned because we understood from NHS that they have completely moved to us subtenon to minimize this complication. When we did that, from 2000 onwards, 17 onwards, the anesthesia-related perforation completely went away, which means we had prevented 92 potential perforation. When you have a perforation, nearly 50% of these patients have very poor outcome. The third part is how do we minimizing the post-operative endophthalmitis. So, like any other organization, we put a lot of focus on sterilization, disinfection protocol until 2014. And during that period, our infection rate used to be 7 to 8 cases per 10,000 cataract surgeries. And in the year 2014, we adopted intracameral moxifloxacin. Dr. David Chang was one person who really pushed us into adopting intracameral. We did a pilot in the hospital Madurai, and then we scaled it across all the hospitals. And we also published, after adopting it across all hospitals, we had published about 600,000 surgeries, what has happened. And when we switched over, the incidence dropped from 7 or 8 per 10,000 to 1 or 2 per 10,000. It was actually phacoemulsification, it was just 1 per 10,000, and small incision is about 1 per 20,000. And still we continue to have the incidence below 2 per 10,000. And this means in 2024, we have prevented 257 potential endophthalmitis compared to the rates we had in 2014. So just to summarize, the outcomes of safety measure is, so when you have a safety protocol, it also improves the communication between the caregivers and the patient, which improves the patient trust. The staff also have a better clarity of their job. The incident reporting, we are able to detect the problems earlier and also address it. When you don't have sentinel events like globe perforation, endophthalmitis, you also have a much better work atmosphere. The second part of my talk is about effectiveness, which is about how do you minimize the complication, how do you maximize the visual outcomes. And we had created a cataract surgical outcome monitoring called CATQA, where earlier we used to have a manual data entry, now we have a real-time data entry from the EMR. And the surgical outcome the monitoring parameters include the preoperative data, the surgical data, post-operative, follow-up, and endophthalmitis. The surgical, the important one is we track the intraoperative complication. Post-operatively, we track the resurgeries, and follow-up, we look at the follow-up, uncorrected vision, miscorrected vision, and also the follow-up compliance. So this is what a doctor will be able to see. Every month after the follow-up visit is over, the doctor gets a mail and they'll be able to access the software and they'll be able to see all the parameters. They are in the different sections, the paying section, free section, camp section, the pre-op, intra-op, post-op, follow-up, and also we look at the biometry part as well. So we using this, what do we do with this data? We have weekly complication review meeting. We review every patient. This happens every week. We review every patient who had a surgical complication. We review every patient who had a post-op complication, who had a resurgery, and the patient who came back with an infection. And again, overall post-operative visual outcome. And the thing is whether it was managed well, what is the outcome, who managed it, is there anything we did not do, what is it we did, we could have done to prevent this complication happening as well. And based on what we learned, we also segregated all our pre-op patients into 3 groups. A normal group, a group we called as a complex, which includes high myopia, hypermetropia, small pupil, angle closure suspects, post-keratoplasty. And then we have a high-risk group, which includes cataracts following post-VR surgery, post-radial keratotomy, patient who got a nanophthalmus, or patient had a subluxated lens, or a nanophthalmic eye. And we also had created a provision in the EMR to mark this group so that we are able to take good care of these patients. And again, we also put a lot of focus on training our residents and fellows. The numbers of that varies anywhere between 170 to 200 people. We have to really train them well. We use the OSCAR scoring as well. And again, we also have an option to benchmark. I can benchmark myself with a surgeon who does maybe like 1,000 plus surgery. The hospitals can benchmark themselves. So that option is also available. We also track the accuracy of biometry because it's very important for the uncorrected visual acuity. So this is the data for the 2024, and then the spherical equivalent within 0.5 diopter is around 93%. And again, for each individual biometrist, also this is tracked so that we are able to keep the quality. And this was published, a 7-year trend in cataract surgery indicated quality outcomes. So we looked at about 1.86 million case records from the year 2012 to 2018. And of the 577,000 phacoemulsification procedures done across 10 hospitals, so we didn't take the hospitals which were recently started. The complication rate dropped from 1.3% in 2012 to 0.7% in 2018. The reoperation rates, however, remain the same. And again, of the 1.24 million manual small incision cataract surgeries we have done, there is a reduction in the intraoperative complication rate from 1.8% to 1.3%. So I feel whatever steps we have taken has helped over a period of time. And when you have a data and when you act upon that, you'll also be able to make a change. And again, this is a thing that shows the visual acuity outcome. The uncorrected visual acuity of 618 or better, which is the WHO norm, of manual small incision cataract surgery increased from 66% in 2012 to 85% in 2008. You may not see such a clear change in the uncorrected visual acuity of phacoemulsification, but here again we had a statistically significant improvement, even though we may not be able to see that graphically here. And just to summarize, the monitoring has helped us to improve the quality, the sharing of the data and benchmarking between the individual surgeon. With the individual surgeon really made them take their own effort to make things better. We also put a lot of, to improve the visual acuity, the uncorrected visual acuity to make it better. We changed the incision architecture and the wet lab practices, monitoring of the minimal of the surgical training, and also the using the simulators all have helped to minimize the surgical complication. We also try to see what are the cases. We have a provision to look at what causes, what are the patients who have poor vision and what is the reason for that. Also we'll be able to track from that. And we also have done work, we also have found some of the IOLs, the A constant was appropriate because the refractive error we get in those patients were very difficult. And again, to conclude, any organization, if it wants to achieve excellence in quality, you have to focus on what goes wrong in the organization. That's very, very important. When you know what is going wrong, you have to find the root cause and you have to collect the required data, and you have to find evidence-based solutions for improvement. All these are available. Once you are able to get that improvement, then you have to empower the team. So it's not an individual's work. You have to empower the team to implement it and make a change. Thank you.